I have the challenge of discussing hot topics in surgery in regards to breast cancer. It's actually sort of a tricky topic because as a surgeon, we only have so many options. We heard about all these wonderful new drugs and different targets to attack cancer cells. Surgeons essentially have a knife, and I can't get up here and say that we have sharper knives. So as far as updates go, it's actually sort of a tough talk to put together, but there are some interesting things that we can discuss. And I need to point out that I have no financial disclosures. This talk is intended for anyone that showed up to listen to it. So the first half of the talk, I'm going to talk about surgical margins. So anytime in any surgery, honestly, margins are always a hot topic. And with breast cancer specifically, there's been years and years of debate as to what a good margin is and what to do if you think you have a concern margin. And recently there have been some consensus statements released by multiple medical committees that have helped to delineate what we call a true positive margin or negative margin for that matter. And then the second half of the talk, I'm going to talk a little bit about, I entitled it Sentinel Node Frozen Analysis, ? The underlying question is more, what do we do about the axilla from a surgical standpoint? Because there's a lot of new evidence that suggests more surgery is not always best. So surgical margins. So before breast conservation therapy became popular, margins was not really a big hot topic. And what I mean by that is when everyone got a mastectomy, your chances of getting negative margins were very, very high. And this whole idea of having a positive margin really didn't exist. But as in the late 1970s and 1980s, when we were understanding that you could do a lumpectomy and offer the same oncological outcomes as a mastectomy, but thereby take less breast tissue out. Obviously, patients were excited about that option, but it introduced this idea of a positive margin because we were trying to take less tissue. I gave a similar talk to a group at UAB, or North Alabama, as Dr. Dias labels it, and it was interesting because Dr. Urist, who is sort of one of my mentors and the patriarch of breast surgery with Dr. Bland up at UAB, he had just published this paper about what is a true margin, or what is a clear margin. So why are margins important? Why do we worry about having a negative margin? And what we know is that if you have a positive margin after a lumpectomy, your recurrence rates are higher. Some studies quote that rate up to 20%. The factors that contribute to that are the age of the patient, obviously. If you have a very young patient who's going to live a very long time, they have a higher chance of having a recurrence. The tumor factors, such as the grade of the tumor, whether there's lymphovascular invasion, whether the lymph nodes involved, all these things sort of contribute to the likelihood of having recurrent disease. One of the strongest predictors of having recurrent disease is your margin status. And this is, my 3-year-old son could tell you that. If you leave tumor behind, there's a higher chance it will grow back. So, excuse me. These trials listed here on this slide, I'm going to try to figure out which one points. These are all trials that were performed a long time ago, but these are the trials that led to us accepting breast conservation therapy as a acceptable practice. And these are the trials that said that you could do a lumpectomy and have the same results as a mastectomy. But these are the trials that led to the whole debate of the importance of margins. So let me just fast forward here. So what is a negative margin? Or the other way to look at this is what is a positive margin? These are all different definitions that have been quoted in the last 10 years as to what a positive margin is with invasive breast cancer. Some people have said a positive margin means there's disease at the actual margin. Some people have gone a little bit further and said that a positive margin is actually when there's disease close to the margin. And then we have different definitions as to what is close. Is it 1 millimeter? Is it 2 millimeters? Is it greater than that? In 2006, this was such a hot topic that they had a consensus conference on breast conservation where they specifically addressed what is a true margin. And after days of debating and talking, they agreed to disagree about the width of the margin. So even when you got a group of people together to try to address this topic, they couldn't come to any consensus. The American Society of Breast Surgeons then released a statement that essentially said that that this gray zone, they thought a positive margin meant ink on the edge, and that less than 1 millimeter could still be a positive margin, because they sort of left this up to the surgeon to decide what do you want to do in these situations. And then the Mastery of Surgery textbook, which is all surgery residents have this book. This is sort of our go-to reference when it comes to all things surgery. This is what it said in their 5th edition. It's about 10 years old now, but acceptable surgical margins by most radiation therapists exceed 2 millimeters in all planes, and it was thought that anything less than 2 millimeters is a positive margin. So I highlight all this just to show you that there has been some debate as to what is a real negative margin. These two studies are older studies. They essentially have shown that, and we switch gears a little bit, talking about in situ. So this is not invasive breast cancer, but talking about what is a negative margin in situ or breast cancer or DCIS. These two studies show that similarly in DCIS you can do a lumpectomy and have excellent results. You know, you can do a lumpectomy with radiation and have long-term disease-specific survival of greater than 95%. These studies did show that if you have a positive margin, your chance of having an ipsilateral breast tumor recurrence or having a recurrent cancer is significantly higher. So this essentially just confirmed that positive margins are bad. Other studies, and I'll just briefly go through this, have shown that positive margins are bad. Again, in situ breast cancer or DCIS, the definition of what a real margin is has been very vague. Some people quote less than 2 millimeters, some people say greater than 5 millimeters. There was no real acceptable definition. And again, the Mastery of Surgery textbook in regards to in situ cancer had a similar vague statement as to what a real negative or positive margin is. So this is a very interesting study. In 2010, this questionnaire was sent to sent to a lot of breast surgeons. 318 replied, and it simply gave them 3 scenarios and said, what would you do in your practice? So the reason I highlight this is, as just 10 or 8 years ago, there's great discrepancy in what one surgeon would do as opposed to the other surgeon in regard to a margin. So scenario A here is a 60-year-old female with a very small invasive triple negative breast cancer. They're planning on getting radiation therapy. You ask the surgeon, what margin do you need? About half of them say you need a margin greater than 1 to 2 millimeters. Interestingly, 1 out of 5 or 20% said you need something greater than 1 centimeter. So I point this study out just to highlight that as early as just 8 years ago, there was a wide spectrum as to what breast surgeons thought was a good margin. The reason I highlight all this is today, at least they say that 25% of patients who undergo a lumpectomy end up going back to the operating room for a second procedure or second operation. And I think that's in a very high number. And you can see here, half of those reoperations are to achieve more negative margins. So you have a close margin, you want to go back to take more out just to help prevent that cancer from coming back. And vast majority of those final pathology reports reveal no residual disease. So that begs the question is, why do you subject these people to a second operation? And as we heard just a minute ago, there have been some very significant improvements in how we treat people, both with adjuvant therapies. We now have majority of patients are receiving hormone therapy. We have improvements in radiation delivery and focusing our radiation energy, and all these things point to the question of how surgically are we helping these patients by taking them back to surgery for something that we can't even find on pathology. So let me just fast forward. So in 2013, an expert panel was brought together, and this included people from the SSO, which is sort of the surgical group, as well as ASTRO, which is the radiation group, and ASCO, which is mainly medical oncology group. And they all got together and they debated what do we call a positive margin. And these are all the big hitters when it comes, a lot of the people around the country when it comes to breast cancer treatment. So there were 33 studies that they reviewed. They looked at over 28,000 patients. There were 1,500, within those 33 studies, 1,500 patients had a tumor recurrence. So about 5% of the time patients had recurrent disease. And essentially, I'll just fast forward to what they found. Their concluding statement was that in invasive breast cancer, a positive margin is defined as ink on tumor. So if you have a specimen that's close, but there's, it's 1 millimeter or half a millimeter, that's defined as a negative margin. And there's no role for going back to surgery to get more negative margins. That is sort of the takeaway message from invasive breast cancer. They also concluded from reviewing these studies that the choice of giving radiation therapy adjuvantly should not depend on the size of the negative margin. Obviously, if there's a positive margin versus a negative margin, you can recommend radiation. But if it's 1 millimeter versus 3 millimeters, there was no benefit from, using that to decide who gets radiation therapy. So in conclusion, no ink on tumor for invasive disease. The same panel, almost the same players, got together in 2015 and addressed the question of in situ breast cancer. Similarly, there were large meta-analysis of 20 studies, and they found in DCIS, their concluding statement was margins of at least 2 millimeters are associated with the reduced risk of tumor recurrence. That essentially says that ductal carcinoma in situ or in situ cancer, you need a little bit wider margin than invasive cancer. And that's what we've all expected all along, but these expert panels sort of confirm that. So I think the current practice pattern is in ductal carcinoma in situ, it's important to have a margin at least 2 millimeters. Obviously you can, apply, and I'll sort of get to this here, clinical judgment should be used, apply this on an individual patient-by-patient basis. This question always comes up is what do you do if you have a tumor that has a ductal carcinoma in situ with an invasive component? And their consensus statement is that you use the guidelines for the invasive component. So if you have DCIS with invasive carcinoma, then you won't no ink on tumor. Is the way they interpret that. One thing I wanted to point out, there's this volume of disease. So I have a lot of patients who have DCIS, and they may have multiple margins that are very close. The specimen may be a wide, ductal carcinoma throughout the, DCIS throughout the specimen. And that's an entity that people are describing as extensive intraductal carcinoma, or EIC, and I think those tumors behave a little bit differently. I think if you have a specimen where the entire thing is DCIS and all the margins are close, that's someone I would consider, a mastectomy for, because the likelihood of them having residual disease is very high. Their biology is different than a lady that has a focal area of DCIS. I'm going to fast forward real quick to talk about the second part of the talk. So sentinel lymph node biopsy was first developed in melanoma. Dr. Morton out in California did a lot of work with this and became a part of treatment of melanoma. And since then there have been many studies in melanoma as determined is sentinel lymph node biopsy actually therapeutic, or is it just purely a diagnostic procedure? Nonetheless, this was applied to breast cancer in the mid-90s, and it allowed for us to understand the status of the axilla surgically and help determine prognosis in a lot of patients. So we all know these numbers, but essentially sentinel lymph node biopsy is a very specific and sensitive technique for identifying disease within the axilla. The ACOSOG Z11 study that came out, I guess, 5 or 6 or 7 or 8 years ago, essentially looked at whether or not in someone with a positive sentinel lymph node, whether we should do an axillary lymph node dissection versus do nothing and let them get axillary radiation as they were planning on getting. And then we all have learned this study, but essentially what they found was that in a patient with a positive sentinel lymph node biopsy and 1 or 2 sentinel nodes, there was no overall survival benefit or local regional recurrent benefit in doing an axillary lymph node dissection, and these are from that trial. And so you can see, and their follow-up was over 6 years, and then they recently released a 10-year follow-up. And in the group that had the axillary lymph node dissection after having a positive sentinel node, 6% had recurrence over that 10-year period, as compared to 5% in the group that got a sentinel lymph node biopsy. You can see the overall survival numbers. So essentially, when this trial was published, it made us start questioning, do we need to do an axillary lymph node dissection for somebody with small volume disease in their axilla who is going to get radiation nonetheless. This is an interesting slide that I found that looks at how many frozen sections they did at this group in patients who were getting lumpectomies. You can see in 2009 and 2010, 100%, so every patient that had a lumpectomy got a frozen section analysis of a sentinel node in the operating room. Once this trial was released in early 2011, I believe, you can see the number drastically dropped off. And essentially, so surgeons concluded, and this paper summarizes it well, that if I'm not going to do an axillary lymph node dissection, there's no point in me doing a frozen section analysis of a lymph node in the operating room. We should just wait or defer to final pathology. So MD Anderson published this paper looking specifically at this question. And since the Z11 trial was published, they had 400 patients who were undergoing a lumpectomy. 350 or 90% of those patients had a negative sentinel node biopsy. So 48 or about 10% of those patients had a positive sentinel lymph node biopsy. Based on the trial, only 8% or 4 of those patients needed an axillary lymph node dissection. So you can conclude that 4 out of 400 patients actually need an axillary lymph node dissection. With that information, they said there's really no point in doing frozen analysis of a sentinel lymph node in the operating room because there's a 1% chance that that patient's going to need an axillary lymph node dissection. Interestingly, they found that the cost, so the cost of doing a sentinel lymph node biopsy in a patient is about $4,000 with frozen analysis. If you eliminate frozen sectioning, you can drop that cost to $2,000. So their practice now is that no one gets frozen sectioning of sentinel lymph nodes if they're getting breast conservation therapy, if it's a lumpectomy. And the reason I say that is, it has to fall within the guidelines of the Z11 trial. So can we extrapolate the Z11 trial to mastectomy patients? So when they designed the Z11 trial, it was only for women getting breast conservation therapy, only for people who are getting a lumpectomy. And then the question is, can we say a mastectomy patient, these same rules apply? And they were not included in the trial, so the general consensus is that we cannot extrapolate that. So in a mastectomy patient with a positive sentinel node, a lot of people would still recommend an axillary lymph node dissection. There was a trial that was published called the AMAROS trial, and I'm just going to skip to it real fast, but it's a European trial, and it was built very similarly to the Z11 trial. So it was a clinical T1, T2 tumors. These ladies were offered either lumpectomy or mastectomy, and if they had a positive sentinel node, they were randomized to either an axillary lymph node dissection, then adjuvant radiation or just or just adjuvant radiation in the other arm. And they found, and this is really strong data, but at 5 years, there was no difference, significant difference in the number of patients who had a recurrence. So doing an axillary lymph node dissection offered no benefit to those patients compared to just doing axillary radiation. The 5-year disease-free survival was also insignificant. The reason we talk about this is that the comorbidities that come with axillary lymph node dissection are very real, and studies have shown that axillary radiation offers less chance of having lymphedema, less postoperative pain, less decreased range of motion in the upper extremity. So we can say that, you can make the case for not doing an axillary lymph node dissection in a patient who is having a mastectomy with a positive sentinel lymph node, and you can quote the AMAROS trial. When we talk about neoadjuvant therapy, so as we learned in our last talk, the majority of patients now are getting neoadjuvant therapy before surgery. Do we need to do frozen section in those patients in the operating room? And the question comes down to, do we think an axillary lymph node dissection helps these patients? And there's actually an ongoing trial, the Alliance trial, that's nearing total accrual. I think it's about 80 to 85% right now, that is specifically addressing that question. So this is a phase 3 trial. It's comparing axillary lymph node dissection with axillary radiation versus just axillary radiation in patients who have had neoadjuvant therapy but then have a positive sentinel lymph node biopsy. So I think when this trial comes to fruition and we get these results, we can definitively say that these people do not need an axillary lymph node dissection. That's really all I have, I believe. So I hope that wasn't too confusing. Like I said, it's hard to find hot topics in surgery to discuss. But any questions? Yeah. So those are age-old questions. So in a patient with DCIS, if they have if their margin is less than 2 millimeters, then I will take them back to reoperate. There are some caveats though. If that margin is a focal margin, and I will go talk to our pathologist, and if they say it's really just this tiny little spot, then the likelihood of me going back to the operating room and finding that area is tiny, is very, very low. If that patient wants a mastectomy, then I will offer them a mastectomy. If I'm concerned about doing a re-lumpectomy and cosmesis, then I will talk to that patient, and it may be somebody that we don't take back if it's a focally involved margin. If it's truly a true margin, there's significant disease within 2 millimeters, then I will take them back. If it's if I remove the pectoralis fascia and it was a deep margin, the teaching is that it's a non-invasive cancer. It's not going to spread through the fascia. So if I feel comfortable that I've removed the fascia off the muscle, then I'm happy with that margin, because I don't think going back to take muscle out is going to benefit a patient who does not have invasive disease. It's not. I think you have to take each case on a case-by-case basis. Some patients can't sleep at night with the idea of having cells left behind, and those people obviously I would be, willing to take back. If it's this extensive volume of disease, then despite what the pathologist says, there's a good chance that they still have disease, then that's somebody I would talk about taking back, and I would probably, talk about doing a mastectomy in that situation. I don't know. So to answer your question, it's still sort of vague with DCIS, but my practice is the 2 millimeter rule. So if there's disease within 2 millimeters, I'm strongly considering taking them back.
Radiation?
So this is, that's a very, very good question. So, so in DCIS, and some of these older studies have defined this, if you have disease within 2 millimeters of your margin, they're significantly more likely to recur. Some studies put that number at greater than 10% of patients will have recurrent disease. Radiation can decrease that chance of recurrence, but it is fairly significant. And when a DCIS recurs, 50% of the time it's an invasive cancer. And that's what you worry about. You know, you took out a precancerous spot, you didn't get it completely out, it comes back, but now it comes back as an invasive cancer. And so maybe we could have a debate. I know y'all are having a debate later. We could have a debate as to the role of radiation and DCIS. Do all patients need radiation after surgery for DCIS? You know, that I feel like every year or so at national conferences, that's like the hot debate. But so to answer your question, honestly, I think it's more difficult to surgically treat DCIS than it is to surgically treat invasive breast cancer. DCIS tends to behave, it's harder to get a good negative margin, I feel like, in DCIS. Because I feel like there's two entities. There's focal DCIS that's, you know, you see on a mammogram, it's in that one little spot. And then there's this other type of DCIS that is more extensive. You think you're going in to take a little spot out and the pathologist calls you and says, you know, it's everywhere. And then you get an MRI and you don't see it, but, you know, I think, Lynn, you've probably been in that situation before. But I feel like with a true invasive cancer, it's more, you're able to get, you feel better about your margin. With DCIS, it's this fuzzy area that you don't know how best to treat it. You know, is surgery better, you know, more surgery, do you help the patient? And I don't think we really know. So, sorry, that was a very convoluted answer. But any other questions? Or all right, that's all I got. So hopefully, you know, I would just say, just to summarize this second part, I think in the next few years we're going to get to the point where an axillary lymph node dissection for the treatment of breast cancer is very rare. I don't know. And maybe we can debate that in the next few years.